Thank you, Dr. Mona, and I would like to thank the organizing committee and scientific committee for the kind invitation. So today I'll talk about the WHO updates on MPN and MDS based on what's published last year on the leukemia journals. And also I will expand more based on what is available online now as a beta version for the WHO classifications for hematolymphoid tumors. Today my talk is only the updates in MPN and MDS, so I'll touch more on MDS, MPN if I have time. We know that the MPN, based on the four major category, the CML, polycythemia vera, ET, and primary myelofibrosis. And also we have the chronic neutrophilic leukemia, eosinophilic leukemia, and MPN unclassifiable. In this version, the WHO add the juvenile myelomonocytic leukemia to be considered as a childhood MPN. There is no much change on the diagnostic criteria. However, there is a slight modification on the chronic phase and also a renaming on the, and some changes in the diagnosis of chronic eosinophilic leukemia. So, in this version, the classification express more on the importance of mutational analysis in MPN, especially in myelofibrosis, and also in ET and MPN if there is atypical feature or sign of a disease. Also, they stress on the presence of germline predisposition in patients of MPN, as first-degree relatives of MPN patients have 5 to 7-fold increase in the developing of MPN, and also since the JAK 461 haplotype allele is present in about quarter of population, and it's hyperactivated and enriched in patients diagnosed with MPN, especially with JAK V617F mutation. I'll start with the chronic myeloid leukemia. So all of us been surprised when the 5th edition classification removed the accelerated phase of CML. We all know that the CML is either biphasic or triphasic, presented with the chronic phase, then accelerated phase, followed by blast phase. However, some patients will present from chronic directly to blast phase. However, in the era of TKI, they feel that the accelerated phase is less useful, and now they call it a high-risk chronic phase, and we will explain more on this. They highlighted an essential and desirable diagnostic criteria for diagnosis of CML. So the patient must have a peripheral blood leukocytosis together with detection of Philadelphia chromosome by karyotype, FISH, or molecular analysis. And this is enough and essential for diagnosis. However, if the bone marrow aspirate is available, this is very important to confirm the disease phase. And a bone marrow biopsy is not that important unless the patient aspirate cannot be taken. The definition of blast phase for CML, more than 20% myeloid blast in the bone marrow or peripheral blood, presence of extramedullary proliferation of blast, or presence of lymphoblasts in the peripheral blood or bone marrow, even if it's less than 10%. So if lymphoblast is present, this is enough to call it blast phase CML, even if the blast is less than 10%. This is the features for increased risk of disease progression. We have a high risk, or what they call it a high risk chronic phase CML. So at diagnosis, present of increased blast up to 19%, or more than 20% basophils, or additional chromosomal abnormalities in the cells carrying the Philadelphia chromosomes, or presence of dysplastic changes in the megakaryocytes as micromegakaryocytes as seen in the MDS. This, or fibrosis. So this is what we called before accelerated phase. Now it's still there, but they call it a high-risk chronic phase. During a treatment, if there is a resistance to the TKIs, if there is a loss of response, if there is a new additional chromosomal abnormality or mutation in the BCR-ABL, this is also included in the high-risk chronic phase. For polycythemia vera, the diagnostic criteria is almost the same. However, they mentioned that if the patient is negative for JAK mutations, a higher hematocrit target could be considered. So if the third criteria if the third of the major criteria is not available, the 2 is enough. However, they are targeting a higher hematocrit level. For diagnosis of essential thrombocythemia or ET, the diagnostic criteria is almost the same. Also, the diagnostic criteria for post-essential thrombocythemia is similar to the last edition. They explained more in the prediction of myelofibrosis post-ET, thrombosis with ET, transformation to blast phase ET with more explanation. So they are saying that any patient more than 70 presence of fibrosis, more than 1 anemia, leukocytosis, JAK negative disease or mutation, another extra mutation in epigenetic regulator as ASXL1, and therapy resistance specifically to hydroxycarbamide. This is a risk factor for the patient to transform to myelofibrosis post-ET. Also, if the patient is a high risk with the age of more than 60 with a history of thrombosis history, then the patient is high risk of ET. Very important, the age, history of thrombotic events, and JAK versus non-JAK mutated genotype as substantial for risk factor to develop thrombosis for those patients. For leukemic transformations, post-ET, again, the age, the leukocytosis, abnormal karyotype, thrombosis, if the platelet is more than 1,000, presence of reticulum fibrosis, and therapy resistance especially to hydroxycarbamide, and as we said, the mutation or high-risk mutation like TP53, RANOX, and ASLX1. For myelofibrosis, the diagnostic criteria is unchanged. For prefibrotic, fibrotic, the grading system is the same for reticulofibrosis, collagen, and osteosclerosis. They mentioned a very interesting statement that recent studies showed that presence of what they call megakaryocytes activations. It's a triad that comprise megakaryocytes, imperiopoiesis, clustering of 3 or more megakaryocytes, and pre-megakaryocytes fibrosis. This is specific for predicting a fibrotic evolutions in any patients of ET, BV, or even early primary myelofibrosis. Also very interesting that a new immunohistochemical staining for megakaryocytes, it's CAL2. This can establish clonality, and it's correlate with the presence of a mutation of CAR reticulin in that patient. This is helpful as a rapid assessment screening and also in a low resource setting. It's very important to screen the patient for additional mutational positivity, especially as that some mutation carry a worse prognosis as SLX1, AZH2, IDH1, 2, and SRSF2. Mutation in TP53, of course, it's associated with leukemic transformation and unfavorable prognosis. They added this a nice table about the different prognostic score system. We know that IPSS can be used upfront at the time of diagnosis. However, others can be applied through the patient disease. The DIPSS plus include the karyotype abnormality, the MIPSS, the 2 version. We need the mutational analysis to use it, and it's very helpful to predict the disease prognosis. GML, as we said, now they include it under the MPN, and it's considered as a childhood MPN. We have an updated criteria. We have an updated criteria as the mandatory. We need to rule out presence of KMT2A rearrangement. They removed the monosomy 7 from cytogenetic criteria and emphasize more on the significance of diagnostic molecular study for RAS pathways. So for diagnosis of GMML, we have clinical, hematological, and laboratory criteria. We have 5 criteria that all required to be present: persistent monocytosis, less than 20% blast or blast equivalent, presence of extramedullary infiltration like splenomegaly, no Philadelphia, no MLL gene rearrangement or KMT2A. And also, we need at least one of mutational component in RAS pathway or non-RAS pathway. In case that we could not meet the genetic criteria or the genetic testing is not available, then we need 2 of the other criteria as increased hemoglobin F, left shift in the peripheral blood, thrombocytopenia with bone marrow hypercellularity and dysplastic changes or no dysplastic changes in the bone marrow, and hypersensitivity to the GCSF. For chronic eosinophilic leukemia, now we have changed in the name. Before we call it chronic eosinophilic leukemia NOS, so we don't need to call it NOS anymore. Also, they removed the alternative criteria for absence of clonality. Before we say that if the blast is increased more than 2 in peripheral blood or up to 19% in the bone marrow, this is enough even if we don't have a clue to the clonality. And also one of the very important changes that they shortened the period for sustained eosinophilia. In the last edition, it was 6 months, and now it's 4 weeks. However, we need at least 2 reads of persistent eosinophilia more than 1.5. We need evidence of clonality, abnormal bone marrow morphology, and not meeting any other WHO criteria for other defined diseases. Diagnostic criteria for MPN NOS is still retained in this edition of WHO. We required 3 major criteria, and we need to rule out 2 other criteria. So we need a feature of MPN, either a clinical feature, patient presented with splenomegaly, laboratory criteria, peripheral leukocytosis, or increased proliferation of the cell of the blood element, or morphological criteria in the bone marrow, hypercellularity, abnormal megakaryocyte, clustering, fibrosis. If this is available, and we could not, and the patient is not meeting a defined MPN criteria for other non-MPN, and we ruled out other criteria for MPN, MDS, MPN, MDS, or others. And if we have a presence of JAK, karyotypin, MPL, this is enough to call the patient MPN NOS. However, we need to rule out that the patient don't have any history of cytotoxic or growth factor therapy, and also we need to evaluate the patient clinical data, and we need adequate bone marrow specimen correctly to evaluate. If we don't have enough data, if you are in a reference center that you cannot reach the clinical information, or if the bone marrow specimen is suboptimal, then we can put it under the NOS until we provided with a better sample for final diagnosis. However, everything needs to be documented in the bone marrow report. Nothing changed about the chronic neutrophilic leukemia. For myelodysplastic syndrome, of course, myelodysplastic syndromes is a presence of cytopenia in at least one of the hematobiotic lineage, and this is a requirement for the diagnosis. Also, it's recommended that the threshold is the same, which is 10% in all lineage. In this edition, they changed the name from myelodysplastic syndrome to be myelodysplastic neoplasm, but they kept the abbreviation as MDS. And also, they defined the cytopenia to be similar in clonal cytopenia of undetermined significance, MDS and MDS MPN. So hemoglobin of less than 13 and less than 12 for females, and platelet less than 150, absolute neutrophil count less than 1.8 is a definition for leukopenia. For classifications of MDS, now we have two major groups instead of the risk-based subgroups based on blast percentage, presence of ring sideroblast, and also cytogenetic and molecular abnormality, and lineage, number of lineage affected by morphological dysplastic changes in the bone marrow, which we've been used in the last edition. So now we have two major criteria, MDS with defined genetic abnormality and MDS that morphologically defined. So in the genetic abnormality, we have the 5q deletion with low blast and low blast with SF3B1 mutation. And both of them, the blast in the bone marrow is less than 5 and less than 2 in peripheral blood. Of course, we need to confirm the cytogenetic abnormality with 5q or absence of 5q deletions and monosomy 7 and the presence of SF3B1. So if the patient have, the 5q is superimposing the SF3B1, and both of them is superimposed by the presence of TP53, which is the third category, MDS with biallelic TP53 inactivations. Also, it's required less than 20% blast in the bone marrow and peripheral blood. Those patients are usually present with complex karyotypes, and we need to prove positivity of TP53 mutation either by karyotype or by molecular study. Until we receive the result of cytogenetic and molecular, we can define the patient based on morphological subcategory, MDS with low blasts and MDS hypoplastic or hypoplastic MDS, again with a low number of blasts in the bone marrow and peripheral blood. And we have MDS with increased blast, and now we call it MDS increased blast 1 and 2 instead of excess blast 1 or 2 in the last edition. They retained the same cutoff of blast percentage as last edition, and also presence of our rods in the peripheral blood for excess blast or increased blast 2. Under this category, which is increased blast, if we have a bone marrow fibrosis, then the patient can be diagnosed as MDS with fibrosis, and as you can see, with the same blast percentage. They defined a hypoplastic MDS as less than 25% bone marrow cellularity age adjusted. They retained that they kept it as an option to call the subtypes of MDS with low blast and ring sideroblastosis instead of low blast with SF3B1 mutation, or we can use it in the beginning if the ring sideroblast is more than 15 or if the patient is negative for SF3B1 mutations. So it's an optional to use this diagnosis, especially in if the genetic testing is not available. They stressed more that the published data suggests that MDS with biallelic TP53 may be regarded as AML equivalent and for therapeutic consideration and study. Distinction between single lineage or multi-lineage is optional now in the diagnosis. It's not that important. MDS unclassifiable now is removed from the category, from this classifications. They explain more about the boundaries between MDS and AML. It's softened now, however, they stress more on keeping the 20% cutoff for diagnosis of AML. They explain more in this as there is no gold standard now for the enumeration of MDS. Most of the centers, they don't have that well-trained pathologists for enumerations. We know that flow cytometry will give always a lesser percentage for blast in comparison to the morphology. A quality of the sample submitted for patients with MDS, especially if the bone marrow is packed and we have fibrosis, usually we receive a diluted bone marrow aspirate. So this will reduce or concentrate the percentage of blast. And also to avoid over-treating of patients, so they still need the 20% cutoff for blast to diagnose the patient as an AML, unlike the ICC classification.
5 minutes more, Dr. Nahlah.
I'm almost closing. Also, they mentioned that there is a broad agreement that MDS increased blast to may be regarded as AML for therapeutic and clinical trial classification. Childhood myelodysplastic syndrome, we have a change in the terminology, also subtypes. We have a childhood MDS with low blast, and we have also a hypocellular subtypes and NOS, and we have the childhood MDS with increased blast. The change in the name is stress more on the difference between the MDS in pediatric and adult as different disease entity. MDS MPN quickly. There is a major revision in the diagnostic criteria for CMML, and there is also renaming and change in the terminology of other MDS MPN. The diagnostic criteria for others, it's not that change broadly. However, they rename atypical CML as MDS MPN with neutrophilia to avoid misconceptions and confusion between CML and atypical CML. As we mentioned, that MDS MPN with ring sideroblastosis and thrombocytosis redefined based on the presence of SF3B1. However, it is acceptable to call it like this until we receive the result of a mutational analysis. And they removed the term unclassifiable and changed it with NOS. For the diagnosis of chronic myelomonocytic leukemia, now we have the prerequisite criteria, which is mandatory, that every patient sustained a high monocytosis and decreased blast percentage below or blast equivalent as a pro-monocytes less than 20%, and not meeting any diagnostic criteria for other MDS, MPN, or MBN, not meeting diagnostic criteria for MPN, MDS with eosinophilia. We need a supporting criteria for this, either presence of dysplastic changes involving more than or at least one myeloid lineage in the bone marrow, presence of acquired clonal cytogenetic molecular abnormality, abnormal partitioning of peripheral blood monocytes. They included what we called before oligomonocytosis, which is list 0.5 increase in the peripheral monocytes above the 0.5, but less than 1 absolute count. And in that case, we need at least 2 supporting criteria to call the patient as CMML. So if the patient presents with sustained monocytosis more than 0.5 absolute count, then we need a proof for clonal cytogenetic and molecular abnormality and the dysplastic changes in the bone marrow. Still, we have the subgroup criteria for MDS CMML and MPN CMML, and they removed the CMML 0 before, which was peripheral blood less than 2% blast and less than 5% in the bone marrow. Now we have only the CMML 1 and CMML 2 with the same blast percentage as the previous edition. This is what they explain about the partitioning of the monocytosis. This test is done by flow cytometry, entertaining the monocytes with CD14 and CD16. And in case of CMML, we have increase in the classic monocytosis, which is 14 positive, 16 negative. However, in case of reactive monocytes, we will have a good percentage of intermediate stage monocytes and also non-classical monocytes with positivity of 16 and dim to negative CD14.
Excuse me, Dr. Nahlah, 2 minutes more.
So in case of CMML, we do the flow cytometry analysis for partitioning. In the peripheral blood, we found that more than 94% of monocytes are falling within the classical monocyte. This is a very sensitive and specific testing for diagnosis of CMML. However, in case that the patient have other autoimmune, other inflammatory disease, this cannot be applicable. They mention some other alternative tests. They call it SLAN positive monocytes. In the SLAN positive monocytes, usually the healthy donor will have some positivity in SLAN together with CD16. In case of CMML, we don't have a SLAN positivity, and also in case of inflammatory process for a patient have CMML together with autoimmune inflammatory, SLAN also can be negative. So this is other alternative if in case that we cannot apply the partitioning due to presence of autoimmune or inflammatory disorder. This is the end of my talk. I would like also to thank you for your attention, and there is more in the online version. We are still waiting the printout for the WHO 5th edition. We think that it's taking too long time, but it's a good alternative if you would like to visit the websites and explore more.